And I would like to introduce Catherine Santoro.
Thank you, and good afternoon. I'm Catherine Santoro, Senior Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on how telehealth can address disparities, elevate the quality of care, and reduce costs. This webinar is part of NIHCM's Affordability Roadmap webinar series, where we are sharing research and expert perspectives on solutions to our nation's healthcare affordability crisis. Previous webinars have covered the impact of private equity and consolidation on costs and quality, as well as the impact of escalating healthcare costs on the federal budget. Telehealth has improved access to a wide range of healthcare services by overcoming geographical barriers and improving the timeliness of care. Understanding the challenges to telehealth's wide adoption is important for its sustainable integration into healthcare systems. Today, we will hear from a prestigious panel of experts to learn more about the state of telehealth policies, as well as research and strategies to ensure equitable access to care. Before we hear from them, I want to thank the NIHCM team who helped to convene today's event. You can also find biographical information for our speakers, along with the agenda and copies of slides on our website. We also invite you to join the conversation on social media using the hashtag TelehealthNIHCM. I am now pleased to introduce our first speaker, Mei Kwong, Executive Director at the Center for Connected Health Policy. Ms. Kwong leads the organization's work on public policy issues as they impact telehealth on the state and federal level. She is also the project director for the National Telehealth Policy Resource Center. Ms. Kwong is a nationally recognized expert on telehealth policy, and in her current role, she works with the organization's national and regional partners on telehealth issues and oversees their projects, as well as providing technical assistance to state and federal lawmakers, industry members, providers, consumers, and others. She's been published in peer-reviewed journals and is a sought-after speaker at national conferences. NIHCM's also proud to have previously worked with and supported Mei and the center through our research grant program. And we're so grateful she took the time to be with us today to share an update on federal and state telehealth policies and the potential future of those policies. Mei?
Thank you, Catherine, and thank you to NIHCM for inviting me here today, and thank all of you for attending and listening in to this talk. As Catherine mentioned, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy, and I'll be going over just a very high-level overview of the telehealth policy landscape in the United States, both on the federal and the state level, and also what we can anticipate as far as what may happen as far as developments going throughout the year 2024 and the future, and where policymakers may be right now in making those considerations for those future policy updates. Before we get started, a couple of things. I am going to use the term telehealth in my talk simply because that is how a lot of the policy is written right now. It references telehealth or telemedicine, more frequently telehealth. But you may hear other speakers use different terms. We're all really talking about the use of technology to provide health services. So that is basically what we are talking about, though we may not be using the same terminology, but it is the use of technology to provide health services in some way. If we can go to the next slide, please. A few disclaimers before we get started. Please note that any information I provide today is strictly for informational and educational benefits. It is not legal advice. We always recommend at CCHP that if you are interested in a formal legal opinion, that you consult with legal counsel. And if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any type of a relationship, affiliation, or arrangement with such a company. Next slide, please. Next slide, please. A bit of background about, if we could go back, sorry, there seems to be a slight delay on my end. A bit of background about CCHP. We were established actually as a California telehealth policy organization in 2009 underneath the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center in 2012 through a grant from HRSA. What that essentially means is we receive federal funding to provide technical assistance on telehealth policy, primarily to the other telehealth resource centers who are underneath the same funding stream. However, CCHP does provide that service as well to basically the general public. So we've helped everybody from the White House to congressional members to state policymakers, different federal agencies and state agencies, health systems, hospitals, health plans, different organizations. And when COVID-19 hit more frequently, we were dealing directly with consumers and patients as well, and their questions around telehealth. We also, CCHP acts as an administrator for the National Consortium of Telehealth Resource Centers, and what that is the other 14 telehealth resource centers in CCHP a few years ago realized that there was some duplication of development of resources or efforts that we were doing in providing our technical assistance or materials, and we decided to pull a portion of our federal funding together into a common pot to work more collaboratively on projects. So CCHP acts as an administrator of that work. CCHP also has and convenes a group in California called the California Telehealth Policy Coalition, and that is made up of over 170 statewide and national groups who are interested in telehealth policy in the state. Next slide, please. So, to understand telehealth policy in the United States, you need to realize that there's actually two levels for it. There's what's going on with telehealth policy on the federal level and what's going on the state level. And coming out of COVID-19 with the end of the public health emergency last year, the levels, the federal level and the state levels were not actually on the same plane. So they all did things differently and they approached the end of the public health emergency differently. For example, on the states, and again, when I say states, I'm not talking about all 50 states doing the same thing. Each state was doing different things and how they addressed the end of the public health emergency or what they were going to have as their permanent telehealth policies. But overall, when May 11, 2023 hit, which was the end of the national public health emergency, by that point, a lot of states had decided what their permanent telehealth policies were going to be coming out of COVID-19. So unlike on the federal level, they were not making a lot of decisions about what are we going to do now once the federal public health emergency is over. A lot of states had already decided. There were a couple of states that did mirror what the federal government did and did extend some of their policies out to future dates, but for the most part, most states had already made decisions, and those decisions, a lot of them included doing expansions in Medicaid as far as the type of services that you can provide via telehealth and what they would reimburse, where the patient can be located. And more interestingly, also around allowing audio only to be a modality that they would reimburse for. Other items that they addressed in the state level were around licensure issues, as far as making certain exceptions for licensure in very specific scenarios, such as if there was already a patient-provider relationship established, or if there was services being provided within a certain amount of distance from the border of states. So they were doing these specific carve-outs on the licensure issue as well too, but not necessarily, allowing sort of more full reciprocity of licensure. Or you would see states joining professional compacts, licensure compacts, to make that as sort of like a way of addressing the licensure issue. That is still something that states are continuing to look at. So right now, some of the items that we have flagged that are ongoing for states appear to be the licensure and also around prescribing as well too, which is the prescribing issue is definitely mirrored on the federal level, but on the state level, prescribing of specific scenarios, such as for contact lenses or for hearing aids, or for things related to reproductive health. On the federal level, and this is probably what a lot of people may be more familiar with, on the federal level, they did delay a lot of their temporary policies and extend them out until the end of 2024. So the temporary waivers that we saw during COVID-19 on the federal level, particularly around Medicare, have been extended to the end of this year. What's also been extended is allowing telehealth to be used to prescribe controlled substances without having an in-person exam by the telehealth provider or falling into some narrow exception that currently exists in federal law. So the question now becomes like, what's going to happen, because we are at this point 7 months out from the end of the year, what's going to happen to all of these temporary policies? And right now, as far as I can tell, the federal policymakers have not quite reached a decision on what is going to happen. There is bipartisan support for these telehealth policies, but right now what their final decision will be as far as the future of them remains a bit unclear. Next slide. So there have been a lot of hearings over the past couple of months in Congress, also different agencies or different panels have also discussed the future of telehealth as well too. What we've been able to tell is these are some of the sort of major concerns that have been raised in a lot of those hearings, and those are concerns around fraud, overutilization, the efficacy of telehealth, access. Will access be cut off, and parity? Should telehealth be paid the same as the in-person services? And then you'll see like the specific policy issues themselves, they usually fall underneath one or more of these categories. Like, for example, some of you may have seen recently in the news the end of the broadband funding program, the subsidy that they were giving to some people to allow them to access broadband. That funding came to an end essentially because they've used up all their funding. Again, a program that has a lot of bipartisan support, but they just haven't like quite gotten to that step of like extending the funding or adding more funding to it, even though there's a lot of support for it. So that falls underneath, you know, access, and in some ways, it falls underneath the access here, but that's like one of the areas or one of the concerns that policymakers have that the policy that they need to decide on impacts as well too. A common sort of theme that we're seeing running through all these things, all these issues, are concerns over cost and money. Also, the importance of data, because they're asking for data to show that there isn't fraud or to show that this actually works. And also impacts on patients and disparities. Again, like running across all of these in some ways or multiple issue areas. Will patient lose access? You know, if we make a decision on parity, does that also impact like the patients in some ways? Efficacy, that's obvious. You know, does this work for patients? Does this improve health of patients? If we can go to the next slide. So some of these things I think have sort of been answered with some of the work that's been done over the last couple of years and even recently as well that do address some of the policymakers' concern. And if you listen to some of these hearings and these meetings, you do see witnesses bring these items up, these resources up as well too. For example, concerns over utilization. The Medicare Telehealth Trends Report from 2024 has shown actually utilization, at least in the Medicare program, has gone down like since the height of like the beginning of the pandemic. So we've had like sort of the most liberal telehealth policies out there, but we've seen it like actually be used less as we've gone along. And I think that was to be expected just simply because of, you know, the change in the environment. Concerns over fraud. There's actually been a couple of studies by the Office of the Inspector General saying that, you know, there hasn't been like the widespread fraud in telehealth or telehealth claims that they thought there were. There's been telemarketing fraud out there that telehealth has been associated with, but telehealth claims itself, they have not actually found a lot of fraud. And then as far as efficacy, I just pulled out like one area that's around the use of telehealth for to address opioid use disorders. There have been studies on there showing that it actually has helped, and it's like lower sort of bad outcomes for it if telehealth is used, sort of like more adherence to their medication and also lowering fatal drug overdoses. So there is evidence out there that could alleviate some of the concerns raised by policymakers. We go to the next slide. Parity is a little bit more different. So there's actually been arguments for parity and against parity. Against parity said, you know, why should we be paying the same? The overhead costs are not the same as they are in person. The service itself is different from in person, so it should be paid less, etc. Those for parity have countered that by saying, like, well, you know, sometimes the overhead costs, especially if you have both an in-person practice and a telehealth practice as well, you still retain those overhead costs. And also, a lot of people have also pointed out that you know, things are different for what a urban provider may experience compared to a rural provider. So maybe an urban provider is able to distribute, depending on like how their practice is set up, able to like absorb those costs, those overhead costs, for example, and not have parity in reimbursement, whereas the same may not be for a rural provider. And also noting that perhaps having a lack of parity for the reimbursement of telehealth may actually discourage adoption for it. So providers might say, like, well, why bother offering services via telehealth if you're going to pay me less? I'm just going to stick to an in-person practice. So there have been, like, you know, valid arguments and reasons raised both for and against, and that's been one thing that's made policymakers struggle over, like, you know, what direction they should turn on this question. Next. Data. Now, this has been the interesting thing. One thing policymakers always demand as far as like helping make their decision is like the data there. And I've shown a couple of things, such as like on utilization and on like the efficacy. There is some research, there is some data out there, but they still are asking more. And you know, the interesting thing about this, as far as like data collection and what data they're asking for, we're seeing more and more groups trying to like collect that data and provide it. And I think probably the most interesting thing that we're seeing developed here are actually Medicaid programs making a serious effort to collect telehealth data. This is a snapshot from like the California Department of Healthcare Services that oversees the California Medicaid program. They've created a data dashboard now to show what telehealth utilization is, like the demographics of like people who are using telehealth, and that's all available publicly on their website. And we're seeing more and more states do this. So we are slowly getting to some of that data that perhaps may push those policymakers to make a final decision here. Now, what are possibly the final decisions that they may make? As I said, we have, like, at least on the federal level, 7 months before, 8 or 7 months before the end of this year, where everything essentially like stops, all these waivers, all these temporary allowances here. I'm not quite sure where they may go. I think it's probably becoming more and more likely that on the federal level, we may see another extension just so they have more time to make a decision. But it will be interesting to see, like, you know, if these questions that they bring up around, you know, access, disparities, and the data, will they be satisfied with what's coming out, what's being generated now throughout the year? And I think if we go to the next slide, I think this is my last slide here. This is just some information on CCHP, our website, and newsletter you can subscribe to. And then the next slide, I think, is just our contact information. And I just want to say thank you, and I'll hand it back over to Catherine.
Great. Thank you so much, May, for this great update on policies, as well as, you know, some of the concerns related to future policy and decisions. May mentioned the importance of data to inform future policy, and our next speaker will delve into this a little bit more and share the work, share his work and the work of his new center. We're so pleased to have Dr. Saif Khairut, the principal investigator of the new Center for Virtual Care Value and Equity. Dr. Khairut is the Beekster Blackwell Distinguished Terp Scholar and Associate Professor at the University of North Carolina at Chapel Hill. Dr. Khairut holds joint appointments at the Carolina Health Informatics Program, Cecil Shep Center for Health Services Research, and the School of Nursing. As a health informatics expert, he investigates developing, implementing, and evaluating health IT solutions to improve health equity and access. He's authored over 90 influential scientific articles in more than 35 peer-reviewed high-impact journals and conferences. We're so honored to have him with us today to learn more about his work to use data and research to accelerate virtual care equity.
Thank you so much, and good afternoon. As introduced, I'm Saif Khairat, professor at University of North Carolina at Chapel Hill, and today I'll be speaking about our new Center for Virtual Care Value and Equity. And previously, I was the co-principal investigator of the Great Plains Telehealth Resource and Assistance Center, focusing on 6 states in the Great Plains region, and it's a funded center from HRSA. And we continue to do research that actually informed the development of this center, looking at utilization of telehealth pre-pandemic and during the pandemic, and also some of the challenges that we've been facing. And we identified for the center that there are 2 main themes that we are interested in further exploring. One is, how can we make virtual care that encompasses telehealth and other digital modalities, how can we make it more equitable for patients and more financially sustainable and valuable for providers and programs and institutions? And those 2 themes drove the idea of the center. Next slide, please. So the Center for Virtual Care Value and Equity, VIV, was established in 2023, funded by the NIHCM, the National Center for Advancing Translational Science. It's a 5-year award for $3.7 million to accelerate and be a catalyst for research in the virtual care realm. Again, focusing on those 2 areas of making it telehealth and virtual care more equitable for our patients, and also more sustainable from program sustainability and continuity of care standpoint. The center has national partnerships with the Center for Telehealth within the American Heart Association. We also are working very closely with the AAP, the AMA, and the local government in North Carolina and our healthcare system at UNC, as well as with health economists from RTI International to ensure the cost effectiveness of virtual care and identifying ways to measure and evaluate ways to make it financially sustainable. Next slide. So there are 4 main goals for the center. One, we realize, and building on what my colleague May earlier said, is there's a dearth of evidence when it comes to the real world data in telehealth. Specifically, understanding what data is being collected at the point of care, to what extent is that data complete, what are the gaps in the data that we currently are experiencing, and how can we improve our measurement approaches to ensure we have comprehensive and longitudinal data that could be used for monitoring, evaluation, and research purposes. So we're building a library or a repository of real-world data related to virtual care visits. That includes telehealth, e-consults, hospital at home, and other virtual care modalities. What we hope to build from that exercise is expertise around what our current data structure looks like, ways that we can improve it, and how can we measure if our data repository in different centers and in different institutions across the country are collecting the right measurement and in the right format. Our second goal is identifying one of the issues that we've been facing, that we had to suddenly switch from in-person to telehealth. And that was kind of problematic, that we did not have evidence-based practices on how to establish and implement telehealth programs. And so one of the goals is going to be to develop and validate instruments or frameworks that can inform how institutions and programs and companies can stand up a telehealth program that, again, serves the equity piece and value to make it sustainable from a financial standpoint. So that's going to be a second goal for the center. And the third is identifying what are the facilitators and barriers to using telehealth, and focusing specifically on underserved populations. We'd like to know, we recognize that telehealth has the potential to bridge disparities, but we also realize that there has been some subgroups left behind during the pandemic as a result of lack of infrastructure or not having access to digital tools. And so identifying for vulnerable populations, what are their needs? How can we make telehealth more equitable for them? We're going to do interviews with patients from various underserved populations and disadvantaged populations across the country to understand their needs for adopting telehealth. And on the other side, we're also going to be interviewing providers and programs and executive leaders and policymakers around what can be done to make telehealth more valuable and more sustainable from a financial standpoint, looking at payment models and some of the policy work that May was mentioning earlier. In addition, looking at the provider as an entity and understanding what is the impact of telehealth on well-being. Spending too much time in front of a screen for a full day, are there barriers to a full telehealth schedule versus an in-person or a hybrid approach of integrated health delivery models? And then lastly, the center aims to provide opportunities for trainees and clinicians across the country to obtain certification, education, and resources around telehealth and virtual care. From how do you design a study, what outcome measures should you be thinking about, what frameworks out there that would be a good and a good fit for your project, all the way to the data and data analysis. And we'll be offering consultations in addition to other resources to the public and to interested professionals to be able to build that skill set and knowledge. Next slide, please. So we realize that this is a map of the US that shows the social vulnerability index that was developed by the CDC a few years ago, and it's widely accepted in many studies and also reports. And this shows, the lack of, social vulnerability and the access to care. And the darker colors on the map indicate areas where there is a high social vulnerability concentration in that zip code, and also lack of access or limited access to healthcare. However, the digital piece is still missing. It focuses on access and social, and there's still a gap of understanding which of these zip codes have internet service providers, how many, the percentage of households that have access to a computer. These key fundamental knowledge and data that we need to be able to inform how we can scale up telehealth. Next slide, please. So the problem is, we have a challenge to be in identifying people who lack digital access without having the right tools. And if we don't have the right tools and the right data at our fingertips, we are not going to be able to identify those populations that are in need. What that leads to is unequal access to healthcare services, increased cost for programs and organizations, and lots of inefficiencies. And these can be measured in ED readmits, hospital admission and 30-day readmission rates, and also unmet needs for these underserved populations and rural communities that may not have internet bandwidth and access to digital tools. So this is a key problem that we're facing. And in order to be able to scale up and understand how telehealth can improve access, we need to be able to address the digital piece with data. Next slide. So how can we improve health equity and make telehealth more valuable and sustainable? Well, first, we need a mechanism to allow us to identify which and where are the populations at risk, and why are they at risk? Is it because of social factors, access factors, or digital factors? That's going to allow us to do some risk stratification. We could then use vulnerability scores to understand outreach and how can we tailor our interventions to meet the needs of these individuals in these communities rather than a one-size-fits-all. Number two is earlier intervention. Are we able to identify high-risk individuals and target interventions to improve their health outcomes? If we know that there is a zip code or a community that does not have a specialist or an oncologist, and therefore the ability to do mammograms may not be possible, can we do targeted interventions to improve that? So again, understanding the needs and the gaps at the patient and the population level is key. Number two is to be able to reduce inequities. They do exist, and we know that. And to be able to identify ways to reduce, to improve equity, we have to, again, understand the digital health access, ownership of a computer, digital literacy, and some of these core factors that we have yet to explore at a national level. And then lastly, to be able to monitor and evaluate utilization. Is every patient suitable for telehealth? What disease or conditions qualify for telehealth versus in-person? How can we allocate our resources from an organizational standpoint to offer both in-person and telehealth in an integrated health delivery model, which would optimize our efficiency levels? So these are the needs that we currently have and that we're facing as people in the telehealth space. Next slide. So we've developed a measurement approach, STEM framework. This was done by my colleague, Dr. David McSwain and his team. They developed the Sprout telehealth evaluation and measurement domain, 4 domains looking at health outcomes, quality and cost of care, the individual experience of using telehealth, and program KPIs from a financial and economic standpoint. And then the 5th domain is the equity stratifiers, looking at social determinants of health, health outcomes, and the ways the healthcare is being delivered. So we plan to validate this instrument using consensus from an expert panel that we hope to get from across the nation to come together and critique what are the pros and cons in this model, how can we improve it, and once we have consensus, this will be a validated framework that we then share with key members of the community to be able to implement and use. Next slide. We've also developed a vulnerability index score that takes into account digital health. On this map here, I show this is North Carolina. On the left side, you have the social components. We're looking at factors such as American Indian concentrations in our zip codes, African American, people living under the poverty line, single parent households with children under the age of 18 living on food stamps, households with people over the age of 60 living on food stamps, Medicare and Medicaid patients. And on the left, we have access components. How far is the patient from the closest EMS? How far are they from the closest highway? If they're far away, there's a chance that they are going to delay care. The number of ISP or internet service providers in that zip code, and access to a vehicle to allow transportation. And then you can see in the middle here, we have 3 maps. The first one is the accumulated access components. So it just shows us, if you're interested to know the zip codes that are struggling with geographic access, they are in the dark brown color. And the next slide is the social combined, no, sorry, I'll go back to the previous slide. Yeah, the next map, sorry, is the social component, looking at the most vulnerable, socially vulnerable communities. And then finally, we have an aggregate combined social and access equity map that basically tells us where to tailor our interventions, which neighborhoods and communities are struggling the most. Next slide. So we created this digital health equity score, 3 buckets: social factors, access factors, and digital factors. I've covered the first 2, and the last one is we're looking at the percent of households with internet subscription, number of households with cellular data plan for smartphones, and ability to have ownership of a computer, smartphone, or a tablet. In addition, the number of ISP. This will help us understand the access level to digital tools and whether telehealth would be a good, suitable, and viable solution or not. Next slide. This is a map of the Digital Health Equity Index score at the national level. The areas in dark red are the highest, the zip codes with the highest vulnerability levels, where where there's high social vulnerability, high access barriers, and high levels of digital inequity or lack of digital access. What this will tell us is it will help policymakers and leaders in organizations to hone in on their own states and zip codes and understand the area around them. Sight without insight is a loss, and we need to have data-driven indices like this Digital Health Equity Index score to be able to inform us of where and how can we tailor our intervention to meet the needs of our programs, healthcare systems, patients, and providers. Next slide. So the key takeaways from here is we are interested in adopting, I think the future is going to be integrating telehealth delivery models. It's not going to be one or the other, in-person or telehealth, but ways that we can integrate those two together. Number two, we need a novel way to identify populations at risk using data-driven approaches, and this is what the center is working on. But we hope by the end of the summer that we will have this tool ready for use and ready to be disseminated. And lastly, the need for validated implementation and evaluation frameworks that can drive the implementation and sustainability of virtual care programs. Next slide. So I thank you very much. This is these are there's a QR code if you're interested in participating as a participant or as a subject matter expert. Please join us or email us for any questions. And I thank you all very much for your time.
Thank you. Thank you so much, Dr. Khairad, for helping us understand how you're using data and research to help understand the state of digital health equity. And I know your work will be incredibly valuable to inform both future policy and private sector efforts. Our final speaker will provide us with a solutions-oriented perspective on the use of telehealth for behavioral health services. We're joined by Manny Ariso, Chief Network Officer and President of the Employer Division at Carillon Behavioral Health. Manny is a leader in healthcare, specializing in innovation, public health, health strategy, behavioral health, and healthcare integration. Manny's been with Carillon Behavioral Health for 8 years, overseeing innovation across the business life cycle for specialty behavioral health, foster care, and children with special health care needs within Elevance Health's current and future Medicaid markets. And in his current role, he's also responsible for continuing the development and execution of a robust network access strategy to drive improved network performance and access to high quality integrated care. We're so grateful to have him with us today to share Carillon's comprehensive approach to using telehealth to help solve behavioral health issues.
Great, and thank you. Good afternoon, everyone, or good morning. And so first, before I even dig in, great work that is happening at the center, Saif, and happy to also help participate and bring forward some of our data and information as well as high quality telehealth that's meaningful, that's impactful, is surely an aligned goal that we have aligned back with the center and with overall good public policy. So we can move on to the next slide. And again, thank you all for having me here today. Very quickly, I just want to highlight a little bit about Carillon Behavioral Health. Maybe some of you have in the past have heard of it as Beacon Health Options. Prior to that, Value Behavioral Health, Value Options, and Beacon Health Strategies. And so in March of last year, 2023, we actually changed our name to Carillon Behavioral Health. And so we are, we provide behavioral health solutions directly with states and local governments, as well as the federal government. We also work with and for health plans and developing solutions to meet the diverse set of Medicaid, Medicare, and commercially insured membership, as well as also serve many large employers and support them either with their EAP offerings and their employee assistance offerings and or just their broader mental health and substance disorder needs. We currently have, over 40 years in the industry, about 45,000 EAP providers, covering over 50 million lives and over 140,000 NIHCM providers. As you see, we're actively, through our channel partnerships, both virtual and from a brick and mortar perspective, expanding our networks fairly significantly, both for EAP as well as for our mental health and SUD programs. So that's a little bit about us. One of the other areas as we think about our broad behavioral health strategy, we really bucket it in 3 areas. The first area being access. And when we say access, we don't just mean the number of providers in the network, although that is important, but overall, how easy is it to get into care? Do we understand the care patterns and the data to make the experience seamless and easy for someone to get into care and stay in care? And of course, telehealth is a significant opportunity connected with that. The second strategy pillar is around really focusing on specialized service populations, individuals with significant needs, be it children with autism spectrum disorder, individuals living with serious mental illness, individuals with substance use disorder, really thinking about how best can we align our systems of care to yield the greatest outcomes and opportunities for those individuals. And the last kind of pillar or strategic pillar that we have is really around crisis. How do we support our communities in crisis, be it fires or floods or hurricanes, or be it when situations in our communities occur like a shooting or otherwise? How do we stand up immediate care, oftentimes telephonically, and come around and support those communities? While at the same time, how do we think about individuals in crisis and how do we mobilize crisis connected to that? We currently supporting 10 different states in their crisis systems, deploying and working through those crisis systems to ensure effective use of 988 and effective triage and care as well, which of course, again, has a telehealth component and angle to it as we think about, text and chat and, telephone conversations, as well as kind of virtual, through devices to ensure that there's engagement, there's opportunity, but above all, there's high quality care that folks can get quickly when they need it. Next slide, please. So this slide here really depicts how we think about our overall solutions, right? We have, like I said, a robust network, existing network that sits there, but we also want to ensure that we have the data and the quality behind it, and that also aligns to how we think about paying and expanding solutions. And so when we say digital solutions, yes, a big part of that is telehealth and virtual care, but another big part of that as well is, digital cognitive behavioral therapy, coaching programs, other items that maybe are self-guided and that may meet a need that's episodic or in the moment that we could then help solve for and create capacity in other areas. So really being thoughtful around what is the engagement model, what is the need an individual is having, meeting that need at the appropriate type of care and then also level of care. So as a part of that, thinking even about things like residential treatment, right? How do you think about residential treatment different, not just virtually, but maybe in the home? So again, part of it may be delivered virtually, part of it being delivered in the home face-to-face as well. So back to the point that was stated around how do these things become more hybrid and the opportunities arise to deliver quality care, expand access, while at the same time making sure that the modalities are effective and drive and make sense, yielding for better quality outcomes, and then paying for those outcomes, right? Thinking about how we pay for these opportunities different, right? And ensuring that we have curated pathways for members and patients that actually are connected and that drive value for themselves with, again, like I said, the right type of care and then the right level of care connected back through that with the right off-ramps, right? We want to make sure as we think about telehealth and we think about the quality of care being delivered, if there's a need for an off-ramp because an individual maybe, is entering a situation of crisis, that we have the right safety components in place to off-ramp them into the more appropriate level of care that may be required for them. So really thinking it from a person-first approach, patient-first, person-first approach around tailoring the opportunity, working with the provider communities, working with those telehealth providers and brick and mortar, face-to-face providers to understand what the opportunities are, and being eyes wide open about it, because so much has happened over the last 4 years, right? We have moved so quick and changed so much in behavioral health that now is the opportunity to really, as we continue to move and there continues to be investment and private equity interest in some of these service and delivery models, how do we continue to do that, not slow down, while at the same time really assess, understand the delivery systems, understand the impact, so that we could then also rate and, like I said before, pay for that value. Next slide. And so on this slide here, I'm just going to quickly just really start around how we think about our overall cohesive digital strategy, right? And there's 3 main pillars that are underneath that kind of broader access, but tied into that digital strategy. One of them is around improving access, right? How fast can I get someone into care in rural, non-rural areas? And also certain other types of specialties, right? Services that maybe are, you might be in a service desert for certain kinds of services. So how do we improve access? Meaningful way. How do we improve clinical outcomes, right? Now, let's not just take, care provided face-to-face and put it on a virtual platform. That's great. We can do that. And that's a lot of what we did with COVID, right? Coming in and out of the pandemic. We quickly moved from doing a face-to-face, teletherapy, right? Or telephonic, or, doing it face-to-face, either doing it virtually or telephonically, quickly to make sure that we had continuing to have people in care, have access. But now the opportunity is, how do we improve that clinical care, right? How do we, through all the assets we have, the data we have, the opportunity to capture new data points and structure it in different ways, how do we actually improve and ensure we have fidelity to evidence-based practices into that continuum around improving that clinical outcomes? And the last piece of it all is really strengthening that member experience, that patient experience. How does it translate to the individual receiving that care, right? How does it translate to their resiliency? How do we ensure that they're on a pathway of recovery and resiliency? And how do we tie those things together? So that those are the benchmarks or the strategies underneath our overall digital solution. And so above that, going a little bit more detail, right? Making it easy. How do we make it easy for providers, right? And how do we also advance our engagement models with our members, providers, patients, and making sure that we're investing in the right types of tools? And so very specifically, coming into COVID, we spent, we did a significant effort and investment on webinars and engagement and working with providers to deploy the policies and the PHE to ensure that folks continue to be in care, right? To ensure that providers knew how to engage, what to do next, how to work, where to go, what the changes were. And so we have to continue, now that we're out of that situation, right now that we're post the pandemic, oftentimes, some of that support has been lifted. We have to continue to drive those opportunities, and really just not just tied to access, but really also tied to improving those clinical outcomes. Around expanding access, right? Supporting and contracting with providers across states, thinking about some of those compacts that are currently in place and deploying and thinking differently about, the state sites versus, delivery methodology, and ensuring that, payment policies are aligning right back through that. And then we also want to make sure that we're also partnering at scale, right? And look at those opportunities to scale differently, to provide value differently, and then pursuing oftentimes maybe some non-traditional care modalities, right? Really testing things that may be new, that may be different, that maybe haven't been displayed or worked through. Like, how do we work on those things at the same time as well, to ensure that care delivery is happening and that we're expanding, again, access, improving clinical outcomes, and strengthening that member experience. Which really leads us into paying for value. I've said this a couple times, and how do we think about paying for value, right? So not just paying on a fee-for-service basis, right? But really working through, both from a face-to-face, but also most definitely from a telehealth perspective. How do we align incentives, right? How do we align incentives between payers and providers to ensure that we have a sustainable model going forward for telehealth and for these opportunities? How do we pay for, access guarantees, getting folks into care really quick? How do we pay for not just access to the first appointment, but second and third appointments? How do we move to value-based payment arrangements that take a look at measurement-based care, take a look at functional improvements, take, not just HEDIS and, a National Quality Forum and other types of things into account, but also look at new novel ways of measuring telehealth quality. And again, pay for those things, right? I spoke to around speed to access, incredibly important. But so is therapeutic alignment, right? How do we ensure that that is also existing? And again, aligning the things in a way that are going to drive improved clinical outcomes. And like I said, then paying for those things, right? And oftentimes, instead of just doing bonus payments on the back end or looking at data on the back end, really having a different relationship, but maybe even front loading certain kinds of rates and opportunities, and then playing catch up on the back end if folks and providers are not meeting those measures. So really flipping some of those things on its head. So that's really, so on an overall basis, our focus as it relates to telehealth and how we are looking, and not only looking, but currently implementing it, is with the lens of improving access, improving our clinical outcomes, and strengthening that member experience, and then doing so in a way that creates sustainability for providers and their overall business model associated with telehealth and paying for that value. And so thank you.
Thank you so much, Manny, for sharing Caroline's efforts to support providers and members, and really how you're thinking about the patient experience as well as improving access and outcomes. We're going to use our remaining time to engage in a Q&A with our audience. You can keep sending in questions on the panel. I'll ask our panelists to come off mute and back on video. And wanted to start just with a quick question for Safe. We had a lot of interest in the maps that you showed, especially that national map. And I think you said that's part of your work that'll be available this summer, but could you talk a little bit about that? I think that'll be really helpful. We have a lot of like state and local government agencies on the line too that would be able to use that.
Absolutely. So maybe first I can explain the methodology. So for every zip code, we have two calculations, one which is across the state. And so it's on the decile level of 1 through 10. And where does that zip code fall in throughout the whole state? So it's state specific. And then for the same zip code, we have a percentile across the country. How does that zip code fall within the rest of the country, so that we're comparing the same variables? And so users of the tool will be able to hone in on their state and be able to understand the needs, and also a country nationwide. Currently what we're doing is we're finalizing the data set and the calculations, and we're then going to build a web tool to allow people to be able to generate maps, download the data, be able to use it to their needs. And we don't anticipate this will be for any cost. So it's part of the center's mission to advance the telehealth research and policy. And we also hope to incorporate AI so that people could, large language models, one of the goals is to be able to, for people to just ask questions and say, what is the most deprived zip code in my state? Or what community is really struggling to get health access from a geographic access. So that will be our second phase after the website. So timeline wise, hopefully yes, like the end of the summer or end of the year.
Perfect. We have another question, might be more for Manny coming off your presentation. If any of the practices you're working with ask questions about broadband digital access to patients, how have you been able to accomplish this? What are the next steps then in terms of connecting patients to support?
So
and
we have
Sorry, go ahead.
No, we have two methodologies that we deploy very quickly. So no, they're not asking those questions, but also through some of our care management programs, we will actually deploy kind of smartphones as a part of it under a care management agreement with that member, so that they then do also have access to digital components, at least from a smartphone digital bandwidth perspective, and it comes loaded with certain apps, and it comes loaded kind of ready to go to engage in that care management and participate in that care management activity. But to the best of my knowledge, those channel partners are not asking questions around internet service providers or digital capacities.
Okay, great. We had another question about, well, first a statement from an audience member. We're working to implement telehealth in schools. We're struggling to get parent buy-in in more rural communities. And do you have any suggestions for outreach and engagement to get people on board with using telehealth, especially in rural communities? I guess for any speaker.
I guess my question back would be, well, do they know what their hesitation is? Is it with the technology, or perhaps they don't have the resources? Maybe they don't have the connectivity, or they lack like the, like a smartphone or a laptop. And that might kind of help them decide on, the best approach to explain to the parents. If it's something that maybe if they are working with a certain population, it may be a cultural thing as well too. So they may need to examine that and like how best to approach them, because there are different populations that, you need to like approach them in a different way when you're suggesting using technology to provide services. So try to figure out what their hesitation is. It could simply be they don't want to use it because they just don't have like a laptop or a smartphone, but it could be something else, like perhaps something related to a culture or a language barrier. So that may be something, another answer or way to address that particular issue.
Yep. I would also look for leaders in the community that you can, that can come alongside and encourage the utilization, or at least the review of it, right? It could be a community leader or spiritual leader, whatever it is in that rural community. I'm sure there's folks that are, have certain levels of engagement and opportunity, and getting those folks kind of engaged, working through them oftentimes will also help kind of tip the tide of what may be necessary to get the engagement you're looking for.
Okay. Let's see, we had a couple questions about disability. I know, Saif, you had mentioned disability as one of the factors you're looking on, but just a broad question about, any research on the use of telehealth and also telehealth outcomes for people with disabilities, and how we're thinking about that population.
The research is limited, and there's really is a gap in evidence. What we're trying, that's one of the things we're recruiting people for who belong to this subgroup to be able to understand their needs. But we have seen, people point out the lack of closed captioning, as for an example, for some of our telehealth users being an issue. And also one of the other things that we've seen that's really interesting and has brought an interesting perspective to our work is people experiencing domestic violence and doing telehealth visits. It doesn't make sense in some cases, because if you ask them if they're safe at home, the answer is probably going to be yes either way. And so being able to accommodate, in addition to people with disabilities, also people who are experiencing domestic violence.
Yeah, that's really helpful. We are almost out of time, so I'm just going to ask one broad question for each of our panelists to weigh in on, kind of beyond some of the payment and policy challenges we've talked about today. Like, no one necessarily predicted the COVID pandemic and switched to telehealth, or are there other challenges you potentially see ahead for telehealth in terms of either AI, cybersecurity? There's a lot of direct to consumer telehealth happening with weight loss drugs. Like, what are you kind of thinking about that, our audience should be thinking about too going forward?
I can go first, and I think twofold to my answer. The first one is when thinking of the use of AI and integrating it into telehealth, a lot of concerns around governance and liability. and also patient engagement from the get-go. There's a lot of, and we've seen strikes in some places in the countries, nurses not willing to adopt AI. So there's the AI adoption key question. And then the other thing that we're facing, there is, to the best of my knowledge, a lack of national data for telehealth at the zip code level. So you can get 3-digit zip codes. But I think to be able to advance and to do more investigations, we need to have, just like we have with EHR data and other conditions, a national data set that's representative.
I guess one thing, at least on the policy end, to look out for is as the policy is developing, it's becoming more and more complicated. One of the more recent news articles out there of like the Walmart closing down their clinics, and one of the reasons they cited was the complication on the reimbursement policies. But it's not just the reimbursement policies, it's the other policies that are connected with it, such as, privacy, protection of data. That's going to have an effect on the telehealth use, because again, it goes back to like why a provider thinking, why complicate my life with trying to do telehealth if it has all these rules and regulations on it that they don't understand or are hard to navigate. So I think that's one thing to watch, is that the more the policy is being developed, there also the risk of they're making it way more complicated, or so complicated that it's just not going to be appealing to like use it as a way to deliver services.
Manny, anything?
Yeah, I would just quickly say, from our view is, telehealth can scale pretty quickly and easily, yet at the same time, the potential lack for standardizations, evidence-based practice through telehealth, understanding how we're actually improving clinical outcomes. And then when you think about state-by-state potential policy changes, overlaid with federal changes, does it make, opportunities in certain states for more folks to do telehealth, living in, Florida, but supporting California because their payment methodology and the reimbursements and everything is better? And what does that then really do for access? And specifically going back to rule and equity, to the points in that the map that was shown. So these things have to be cohesive. And so, the challenge is going to be is how do we align these things, both from a policy and payment perspective, that don't create disincentives in certain geographies compared to others, right? And so that's where I think we have to be eyes wide open, because it could be an unintended consequence of a lot of good work.
Great. Well, thank you all for staying with us a few extra minutes. We really enjoyed your presentations and hearing about your work and perspectives. Thank you to our audience for your questions. A brief survey will open on your screen after the event ends, and we'd love to get your feedback. And then we also invite you to visit our website for previous webinar recordings and other resources. And you also can find our infographic on rural health that talks about telehealth as a strategy to support access to care. So thank you all again so much for joining us today.